Hi guys, this is Dr. Tan here. Welcome back to this channel. And for today, we'll be discussing about tuberculosis. TB infection can be broadly divided into active TB infections as well as latent TB infection. For these lectures, we will be focusing mainly on active TB infections, and I hope in the future we will have another video discussing about latent TB infection because that is actually another important aspect of TB care. These are the learning objectives. In the usual manner, I will always start off my lecture by giving you some information about the disease epidemiologies. Following that, we will discuss about the clinical features of TB infections, and most importantly, we also discuss on how to diagnose TB infections. After that, we will have discussions on the anti-TB treatment, and lastly, we will end the lecture by discussing some common missteps in the TB management. This slide serves to remind us that TB is actually a very old disease. Its presence could be traced as far as during those ancient Egyptian times. At the time as I speak, TB is actually a curable disease owing to the inventions and the availability of effective anti-TB treatment. Yet, it still remains as a formidable disease because it still causes high morbidity and mortality in certain low-income nations. The main contributors to these observations are not limited to lack of access to healthcare. It's also mainly because of late diagnosis and also advanced disease presentations. Let's switch gear and take a look at our Malaysian TB status. And this information was actually taken from the World Bank, and this was last updated until the year 2020. You can see that this graph demonstrates to you that the incidence of TB in Malaysia is reported as 92 per 100,000 people. And it's hoped that with more efforts in curbing TB occurrence, we'll be able to bring this line downwards in the years to come. In the coming slides, we will be discussing on the clinical features of active TB infections. But prior to that, I would just like to quickly bring your attention to the front cover of our Malaysian CPG, which was last published in 2012. So let's take a look at this photo at this section here. So it illustrates to you that TB infections can literally affect any organ system. It can affect your central nervous system, your genital urinary system, your GIT system, your bone. Even though primarily it remains to be infections mainly infecting the lung system, which is also known as PTB, pulmonary tuberculosis. After knowing TB infections can literally infect any organs, I hope at this point you will be able to appreciate that TB symptoms can be variable and depends on the size of infections. But nevertheless, some common features or common symptoms that would be present in whether be it PTB or extrapulmonary tuberculosis infections will still remain to be a loss of weight, lost appetite, night sweat, fever, and if this patient is so happen to have PTB or it have a coexisting PTB together with extrapulmonary PTB, then this patient might also come to you with chronic cough or in a very advanced PTB. Sometimes they may also present to you with shortness of breath or hemolysis. Nevertheless, TB disease remains to be a disease that primarily infecting the host lungs, which may be reported to be as high as 75% of all the TB infections cases. So whenever we are seeing a case with suspected TB, these are some general questions that we always elicit because these are actually a known risk factors in developing tuberculosis. So among the questions would be to inquire whether the patient has come into close contact with any patients with PTB or with TB infections, and also we would like to know whether is the patient's immunocompromised because of their underlying comorbids, like having underlying diabetes mellitus, HIV, COPD, and also other diseases like ESRF or active malignancy. And other important history would be that whether has the patient been on a regular use of steroid, because this would actually cause immunosuppression, whether it cause a reactivations of latent TB infections or it cause primary progressions of TB infections. And also we will ask whether it's the patients from a TB endemic country. And lastly, we will always see whether does the patients have any high-risk behaviors. I would also like to take this opportunity to emphasize to my fellow doctors that it's important to have a list of sensible differential diagnosis whenever you're seeing your cases. And in this lecture, I would like to give you some differentials for chronic cough, because ultimately TB mainly affect the lungs, and of course patients with chronic cough you would think of PTB. But keep in mind that not all chronic cough are because of PTB. You need to think of other differential as well during your clerking or during your investigations. As far as PTB is concerned, it's always a chronic disease, a disease with constitutional symptoms. Therefore, chronic cough with constitutional symptoms, the main differentials will always be PTB. However, the other differentials to consider will be lung carcinoma, bronchitis, as well as COPD. So this is quite clear-cut because I believe that any patient with chronic cough, constitutional symptoms for sure, definitely you will work them out diligently, which include a chest X-ray, as well as other workup, whether to look for any pulmonary infections, be it TB or non-PTB lungs infections. So on the other hand, chronic cough without constitutional symptoms are actually very prevalent if you are the doctors in the primary healthcare, and these are the important differentials that you should consider instead. For example, postnasal drip, bronchial asthma, COPD is ACE inhibitors associated cough, or because the patients actually have heart failure, or because of gastroesophageal reflux, and also others. So in summary, history will play the most important part for you to decide what will be your next lines of investigations. Next, we will move on to another important aspect of the lecture today, which is to discuss on the diagnostic approach. Essentially, the types of diagnostic tests that we would undertake would largely depend on the primary site of infections. It's generally believed that the portal of entry of this TB bacilli is via the lungs. Hence, in any patients with extra pulmonary TB infections, for example, TB lymphadenopathy, TB guts, and so on and so forth, we will tend to work them up for PTB as well, provided that it is clinically feasible, meaning that the patients have abnormal chest X-ray changes, or the patient is able to provide you a good sputum samples. Having said that, it's not uncommon for us to see that our patients with extra pulmonary TB infections to have a pristine chest X-ray. Nevertheless, the TB treatment remains the same for both PTB as well as extra pulmonary TB infections. The main aim of a TB diagnostic test is to be able to demonstrate the presence of Mycobacterium TB organisms in the samples that have been sent. Even though the coming slide that I'm going to discuss on will be mainly on the diagnostic approach in patients with suspected pulmonary tuberculosis infections, these tests that I'm going to discuss are actually the same tests that would be ordered in patients with suspected extra pulmonary TB infections as well. It is mandatory for the clinicians to send both sputum AFB direct smear and sputum Mycobacterium tuberculosis culture and sensitivity test at the initial workup. And for now, we are going to discuss about sputum AFB direct smear first before I talk about this MTB CNS. So this photo, as highlighted here, it demonstrates to you the presence of sputum acid fast bacilli on the direct smear. So let's take a look at the advantages and the disadvantages separately. So the main advantages is that it offers you a very fast turnaround time. In other words, you will have the result within 2 to 24 hours to guide your management. On the other hand, the disadvantages that these tests entails will be that it doesn't help you to distinguish the types of Mycobacterium species. So in other words, you won't know whether this is Mycobacterium TB or non-TB Mycobacterium. Therefore, we have to send this MTB CNS for us to determine whether it is a true PTB infections or not. So another disadvantages is that that's more relevant in the subsequent part of the management, because we will repeat the sputum AFB again to ensure that sputum smear conversion has been achieved along the treatment. So you might be a bit stuck when you have this persistent sputum AFB bacilli in certain subjects. It might happen, but it rarely happens, I would say. So is that you won't know whether this is a live or dead bacilli. So coming to this question, you have to rely on your sputum mycobacterium cultures to guide you. So what about sputum MTB culture? So the main advantages that it offers is that it helps to distinguish the types of mycobacterium species. So in this case would be to know whether it is a true mycobacterium TB infections or non-TB mycobacterium infections. This is important because the management approach for both this disease are actually very different. So let's look at the disadvantages. So the main disadvantage is that it's not a test with a rapid results. So it has quite a long turnaround times. It takes up to weeks. So, and also it largely depends on the types of culture medium they are using. You are using the older solid culture with the Lowenstein, Jensen's, or Gewa. It may take up to like 3 weeks for smear positive samples. If the smear negative, it may take even longer, up to 4 to 8 weeks. On the other hand, if you are using this bactec culture medium with the automated liquid cultures, it will be faster. If the smear positive, sometimes around 10 days, it will be available. If smear negative sample, it still take about 2 to 6 weeks. These are just the suggested time frame the result will be available. I think ultimately it depends on the place that you are running the test. As far as I know, most of the time the TB culture will come back like around 4 to 6 weeks. It's also important for the clinicians to be aware of this molecular test. For me, I call this a second line test because this is not a test that we routinely order because of the cost limitations. And also generally active TB infection could be actually established based on the sputum AFB bacilli initially, and to be confirmed with the MTB CNS later on. So talking about the types of molecular tests that are available in a government hospital setting would be this TB gene expert, as well as this line probe assay. So let's talk about this TB gene experts. So the advantages that it offers will be it have a very rapid turnaround time. We're talking about results available within the first 24 hours, and also you'll be able to use the rifampicin sensitivity to rule out MDR TB infections. And on the other hand, for this line probe assay, the turnaround times would range between 2 to 7 days, depends on how they do the test. And also it will provide you information whether this is an MDR TB or not. The downside for this line probe assay is that it can only be done on smear positive respiratory specimen only. So overall, these two tests are able to give you a rapid diagnosis of PTB. So what are the main reasons we order this test instead of the first line test? So we will consider this test when there is an urgent need to confirm or to exclude TB infections, especially in patients who are ill, and also they have an initial sputum AFB bacilli that have been repeatedly negative. Another situations where we will consider this test will be in our patients who demonstrated clinical or radiological deterioration despite being compliant to the TB treatment, because this test will be able to help us to exclude whether has the patients acquired MDR TB, especially rifampicin resistant TB. Another important message that I must drive home is that if you are having challenges or having difficulties in obtaining a good sputum specimens via patient's own expectorations, you can actually refer such cases to a tertiary hospital for considerations of bronchoscopy, where they can actually perform a broncho wash to get these good samples to be sent for these either sputum AFB or for these MTB CNS or the TB molecular test. Another situations would be that when the patient is having a persistent smear negative AFB test, in such cases you may also consider referring them for bronchoscopy to get a more optimal samples. As you know, sometimes such cases could be actually a smear negative PTB. Next, we're talking on the imaging modality that we can consider in a patient with suspected PTB infections. And definitely the first consideration is chest X-ray because it's readily available. And but I think that's besides that, another main point that I must highlight is that all clinicians must be aware or be cognizant about the spectrum or radiological changes that a PTB subject may present with, because ultimately we should be able to make the diagnosis of PTB at the earliest stage so that they will benefit from these NTB treatments. There is a grading system for chest X-ray features of PTB, and these features were actually well highlighted in our Malaysian TB CPG, and I hope at your free time you can actually take a look at these sections, which is actually at the appendix sections, where it will discuss with you what are the X-ray features represented by minimal changes, moderate changes, as well as those with advanced changes. Just to illustrate to you what are the common chest X-ray changes in the patients with PTB. Well, most of the time, the TB cavitations or TB consolidations will occur in the lung epicenters because this area is known to be more well aerated, which is actually a favorite place for this TB bacilli to reside and grow. Having said that, like I mentioned to you, PTB changes exist in a spectrum. Hence, you must actually read more about on this PTB X-ray changes so that you'll be able to detect chest X-ray with TB features at the earliest stage. Well, with that in mind, I have actually provided a few article links that will allow you to learn more about PTB chest X-ray changes. Another imaging modality that we can consider would be a chest CT, which is able to provide a more superior resolution compared to a chest X-ray in identifying early PTB changes, especially those very subtle pulmonary parenchymal changes or some early nodular processes. Having said that, this would not be the first line test that we would consider because of the high ionization risk associated as well as the high cost. Nevertheless, we will consider this test normally in our clinical practice when we need to exclude other important pulmonary pathology or when there is a diagnostic dilemma in certain cases. The investigation approach for patients with extrapulmonary TB would rather mirror cases with pulmonary TB. We will definitely send the specimen for acid fast bacilli direct smear staining and also for this MTB CNS. In certain situations, like in patients with suspected TB meningitis or TB pruritus, in addition to the above tests, we will consider sending the specimen for TB PCR as well. Like I would always say, if you need a really rapid diagnosis, you can consider sending a specimen for TB gene expert as well, where applicable. And lastly, if you have a biopsy samples or tissue samples, please do not forget to send them for this for the HPE examinations. On this right-hand image, it just illustrates to you what a granuloma, a caseating granuloma looks like, which is actually pathognomonic for TB infections. Another point to highlight is that we need to ensure all these investigations or assessment has been done on our patients with a confirmed TB, though generally all these assessment or investigation would have been done from the outset. Once this TB diagnosis has been confirmed or established, we must notify it within the first 24 hours, and this is actually governed by this ACTA 342. This is how the manual notification form should look like, and then in addition, we will also fill out this contact tracing form. So this is the DOCS book where all our patients who is on DOCS treatment will be keeping. So what's the difference between these two? So the peach color is actually meant for patients with smear positive TB. On the other hand, the white color TB DOCS book, right, are meant for those with smear negative PTB or those with extrapulmonary TB. Well, you can take a look at this DOCS book whenever you have the opportunity to, when you are working in this either TB clinic or in the TB ward. Well, just need to emphasize to you that please always review the patient's body weight and also the dosages, ensure that all the medications are correctly dosed. And for those on treatments, we make sure that the medications the patient is taking has been signed off on a daily basis. This TBIS 10B-1 is another important document that all of you must know of because it has to be filled up right at the beginning when the TB diagnosis has been confirmed, and also during their subsequent clinical visits you are required to fill up the follow-up sheet. Now we come to the anti-TB treatment topics. Before I proceed, I think it's important for us to have some fundamental knowledge about the mechanism of actions or some basic knowledge about our anti-TB drugs pharmacologies. It's important because it will allow you to appreciate why anti-treatment need to be continued for 6 months, and also why the drugs must be taken in the combinations. So these are the two main drug activities where our anti-TB drugs will offer. So it will be the bactericidal activity and also a sterilizing activity. So for drugs with these bactericidal actions, it has the ability to eliminate those metabolically active mycobacterials, which normally located within the cavitary lesions, where the concentrations of oxygen pressure and pH are ideal for growth. And also, this action is essential to achieve a clinical improvement and to reduce transmissions. And secondly, drugs with sterilizing activity would have the capacities to eliminate persisting dormant organisms. In order to achieve cure, we need to combine drugs with both bactericidal actions and also drugs with sterilizing actions. Also, most importantly, combinations of anti-TB drugs would also prevent the development or the emergence of multi-drug resistant TB. So, like what I say, this bactericidal drug will be able to eliminate TB bacilli that's growing rapidly, and in this regards, isoniazid followed by rifampicin and streptomycin with those drugs with this bactericidal activity, and for those with sterilization activity will be represented by rifampicin and pyrazinamide. Lastly, this anti-TB drugs also has to be used in combinations. This is important because they could deter the developments of antibiotic selection pressures, which will help in preventing the developments of anti-TB resistance. This table is taken from our Malaysian TB CPG, where it shows you what our first-line anti-TB drugs are, which are represented by isoniazid, rifampicin, pyrazinamide, ethambutol, and streptomycin. And over here, it shows you the weight-based regime. In practice, normally we'll prescribe these medications on the daily basis. And also importantly, we need to supplement pyridosins in patients receiving isoniazid because it's in order to prevent the development of peripheral neuropathy. During the intensive phase, patients will require 4 combinations of antibiotics represented by HREZ. So very commonly we will favor the prescriptions of fixed dose combinations. One of the example drugs will be our Accurate 4, which consists of 4 active ingredients, which is your HREZ. This is useful because it does significantly reduce the pill burdens. And again, this is a weight-based medications, and this recommendation is taken from a Malaysian TB CPG, where you can take a look at this later on. Similarly, during the maintenance phase, we can also have the option to prescribe them this Accurate 2, which are combinations drugs with isoniazid and rifampicin. We must always measure our patient body weight during their clinical visit because weight is a parameter for us to decide whether the patient is responding to TB treatments or not, because we do expect them to gain weight as their overall health conditions improve together with the improved oral intake. Another reason why we must monitor their weight, because like what I have alluded earlier, all the medications are actually weight-based medications. So if you do not, there's always a risk that we might overdose the medications that will increase the risk of adverse drug effects. Or on the other hand, it may actually underdose the medications, especially the patients has put on weight during the course of treatment. In underdose medications, we always have the risk of treatment failure later on. Anti-TB drugs are actually very safe drugs, and most of our patients will be able to tolerate these drugs well. However, there's always a risk of developing adverse reaction toward this medication, especially in a subset of patients who are, for example, having multiple comorbidities or have a pre-existing liver disorders. It should be evident to you that most of the anti-TB drugs will have the potential to cause hepatitis or drug-induced liver injury, especially isoniazid, rifampicin, and pyrazinamide. Hence, liver function tests must be monitored closely during the course of anti-TB treatment. On the other hand, for isoniazid, it has this potential to cause peripheral neuropathy. Hence, because of this, we will always co-prescribe our patients with these paradoxins vitamin supplements in order to prevent this occurrence. Other than that, rifampicin will be a known drug to cause discolorations of the urine or even secretions like tears or that. Hence, we must always forewarn our patient to expect these side effects. So another highlight is that pyrazinamide use sometimes will have the potential to precipitate a gouty arthritis flare. Hence, patient with the underlying gout, right, we must always monitor the gouty symptoms carefully. If time is needed, we might have to place a pyrazinamide with another anti-TB drugs. Lastly, just to emphasize to you, ethambutol will be the drugs with potential to cause optic nerve inflammations, or in other words optic neuritis, which might cause visual impairment. Hence, before starting or introductions of the anti-TB treatment, we will always measure our patient's visual acuity and also the color visions before we start this treatment. Other adverse reactions such as anorexia, abdominal upset, or skin rash, and so on and so forth will be not so specific for each drug. By and large, anti-TB treatments will be limited to 6 months durations. However, under certain clinical circumstances, we can actually consider extending the maintenance phase. So the first example will be a PTB disease with very extensive lung involvement. And then another consideration will be when the patient has some forms of extrapulmonary TB infections like TB meningitis. And also lastly, when there has been some modifications or alterations of medication during the intensive phase where the patient cannot complete this intensive phase of 4 drugs combination treatment, in that case, right, we may actually make it up by extending the maintenance phase subsequently. This flowchart is taken from our Malaysian TB CPG. We summarize to you the recommended actions to be taken during their follow-up. I think this is just a general recommendations. The actions to be taken can always be modified, depends on our patient need. There's one thing we call a rule of thumb that we must always follow, is that after starting them on TB treatments, right, during the intensive phase, we must always see them back in 2 weeks to review the liver function test, like what I mentioned to you, to ensure that they do not, develop drug-induced liver injury at this point. And after that, they can be followed up subsequently at 2 months. You must always trace the MTB CNS to ensure that you are not dealing with drug-resistant TB. At the same time, you will also repeat the sputum to ensure that the sputum smear conversions has been successfully achieved. Let's say MTB show that it's not a resistant TB, then you can safely switch them over to the 2 drug treatments for the subsequent 4 months in the maintenance phase. For your information, patients with newly diagnosed TB infections can be actually treated in the outpatient setting, provided that they are stable and be able to comply to anti-TB medications. Listed here are some of the indications where we will consider admitting our patients for inpatient anti-TB treatment. So the first one will be definitely patients with complicated TB infections, for example like TB meningitis and so on and so forth, and also patients who develop side effects towards these anti-TB treatments. And of course, it depends on the degree of side effects. Those are very mild side effects. Sometimes it can still be managed at outpatient with very close follow-up. Other indication would be, for example, patients with PTB who develop respiratory failure, or they develop superimposed bacterial infections, or they have a difficult or uncontrolled comorbid. Also, we have to admit our patients with multiple default for isolation as well as for inpatient dose. Lastly, patient MDR PTB should also be isolated in a hospital setting for inpatient treatment. Another important aspect of care will be patient counseling and empowerment. I think there are multiple important points highlighted in this slide, and I hope you can take your time to go through this slide at your own. I'm going to end the presentation by sharing with you some missteps that are commonly reported. The first one will be late diagnosis of MDR TB infections, and this is to remind you that patients during the course of treatment, if they do not show signs of improvement, we must always suspect MDR TB infection, especially in those patients who are multiple defaulter. And secondly, will be an unrecognized smear negative TB because of incomplete workup and late referral to tertiary hospital. So in simple terms, it means that patient could still have active PTB even though their sputum and direct smear results are negative, because this is what we call as smear negative PTB. So in such instances, right, you can always consider send a molecular test like TB gene expert, which will provide you a rapid diagnosis, provided that you can get a good sputum samples. If not, please always discuss with your regional respiratory physicians for considerations of bronchoscopy that will allow you to get a good specimen in order for you to exclude smear negative PTB. Thirdly, will be unrecognized adverse drug reactions. For example, like fulminant liver failure, like I will inform to you, signs and symptoms of liver failure are very subtle unless the patient came to you with obvious jaundice. Hence, please remember to monitor our patient's blood parameters during their follow-up. And lastly, we fail to take the right actions for patients who are multiple defaulter. For such patients, it's actually by law that we should admit them to hospital and start them on inpatient doors. At the same time, we will always liaise with our social workers and our psychiatry team to explore the reasons why our patients are the frequent defaulters in order to change their behavior. Thank you for your time. I hope you can support this channel by subscribing to it, and also we will appreciate our likes if you find this video helpful in your medical career. Thank you again, and look forward to see you in the next video, in which I'm going to talk about acute coronary syndrome.